Hi, my name is Annika Metz, and I've selected the bulimia nervosa case study for my narrative case review assignment. This case study involves a 33-year-old single woman, Jerry Atkins, who graduated from college with a degree in landscaping. We learned that she checked herself into the hospital due to her eating being self-described as out of control. She frequently engages in binge purge behavior, which is a crucial aspect of bulimia nervosa. We also learned that she has a history of physical and sexual abuse. Her sister was physically abusive, and her brother was both physical and sexually abusive. I'd like to clarify, her adoptive family, so her adoptive sister and her adoptive brother. She's also diagnosed with PTSD and major depressive disorder, which likely stems from that abuse. It is stated that when she was growing up, she was also teased for being overweight by her peers, and now she believes that her value is dependent on her weight. Her diagnosis of bulimia nervosa which is her Her principal diagnosis aligns with DSM-5 criteria due to recurrent episodes of binging and then recurrent episodes of purging in order to prevent weight gain. Said, while there may have been a genetic predisposition, we're unaware of it because, as I mentioned prior, she is adopted and she doesn't have her birth parents' records. And she suffered repeated abuse, therefore it's likely her eating disorder was due to her situation growing up, combined with Western culture societal pressures to be thin, i.e. the teasing she experienced. The treatment that Jerry received while in the hospital was exposure and response prevention, so ERP, which acts to remove anxiety from the binge purge cycle. So this model allows patients to consume food that they may have binged in the past or are likely to binge, but then not allow them to binge after, or not binge, to purge after. Basically, they have to sit at the table until after they eat, until their anxiety is relieved and they don't feel the need to purge what they just ate. For Jerry, she really struggled sitting at the table and had to sit at the table for over an hour after eating before her anxiety was relieved without purging. However, this did improve over time. She attended informative classes as well on the actual effects of binging and purging and how they are ineffective in weight loss efforts and they're actually harmful to her body. Furthermore, while at the facility, she was scheduled to eat manageable amounts of food 5 to 6 times per day, every 3 hours, in an attempt to eliminate Jerry's abnormal eating habits. Little by little, So early in her stay, meals were entirely planned by hospital staff. However, little by little, Jerry did become involved in preparing her own meals under staff guidance so that she'd be able to do that once she's released from the hospital. The staff encouraged Jerry to eat a variety of foods regardless of caloric content. And then the treatment surrounding her body image was CBT, or cognitive behavioral therapy. She worked with a therapist to identify her negative body image and thoughts and adapt to a more positive attitude about her body. They were able to do this by addressing her PTSD and other traumas as well in therapy, and CBT was successful for Jerry in rewiring her mind and how she perceived her body and value. The first critical thinking question is, what do you believe are the main reasons eating disorders are the most common in Western cultures and in females, and what personality and social characteristics do you think are the most relevant in the origin of eating disorders in men? I believe that the main reasons for eating disorders being so common in Western cultures and among women is due to the intense pressures from society and family members to look a certain way, and that way is being extremely thin. A quote from Oregon Health and Science University states, "Some attribute eating disorders to cultural expectations surrounding body and weight size. They point to media, fashion, and other outlets to promote unrealistic ideals. The majority of women that we see in ads and on television don't actually reflect what the average woman looks like, which leads to women feeling very ugly and feeling very unhappy with their appearance. There are also pressures from family and friends to fit in with peers and that being fat is morally reprehensible. Western society constantly pushes the narrative that being fat is one of the worst things that a woman can be. Therefore, in attempts to attain these beauty standards set by models, women starve themselves and develop eating disorders, such as the one that we see in Jerry. I think that men also experience societal pressures telling them to look a certain way, and that can obviously lead to eating disorders as well. Traits that are most relevant in the origin of eating disorders in men would be high neuroticism and then high conscientiousness. Social characteristics include general insecurity or perhaps a circumstance to trigger this behavior. The second question is, if you were able to design a program aimed at the prevention of eating disorders, what components do you believe would be most important to include in this program? In addition to or in place of the techniques Jerry's treatment, what strategies do you believe would be the most effective for people who have bulimia nervosa or anorexia nervosa? I think I would aim for a healthy body's appearance, aim for acceptance of a healthy body's appearance. The focus and priority should be on health and not appearance. I think with that, the body positivity movement we have going on now, we're beginning to learn to accept our bodies. However, just because we love our bodies doesn't mean we're actually living healthy lifestyles. And I think that's what we should be striving for. Obviously, the narrative about being fat is harmful. However, we are in an obesity epidemic, and the normalization of obesity is not beneficial either. So I would push for healthy eating habits and taking care of your body. This is mentioned in the case study when they mentioned that while Jerry is on the diet she prescribed for herself with oversight of staff, she still loses 2 pounds. And they're okay with that because she was overweight to begin with, and she is losing weight in a healthy way. I think that the general treatment of Jerry while at the hospital was really good. However, if I were to add something, I would prescribe antidepressants, not to only benefit Jerry with her bulimia. Like I said in the textbook, antidepressants are generally considered the most effective for bulimia, but also because she has depression. And then, or I guess she doesn't have depression, she has depressive disorder. And then the third question is, what are the differences between bulimia nervosa and anorexia nervosa in terms of diagnostic features, causal factors, social and familial variables, and so on? Some researchers believe that bulimia nervosa and anorexia nervosa may not represent distinct syndromes, but differ mainly in the degree of actual weight loss associated with restrictive and purging behaviors. Do you believe this is the case, or do you think that the distinction between bulimia nervosa and anorexia nervosa is valid and important? Why or why not? I believe that, so anorexia requires the absence of eating and resulting in being severely underweight, whereas for bulimia that's not the case. I think the distinction is important. Jerry was still slightly overweight despite binging and the ineffectiveness of purging. And another key difference is bulimia often results in patients feeling extremely out of control, like Jerry did. However, anorexia nervosa causes feelings of mastery and feeling good about yourself or starving yourself. I think that they're separate disorders. However, both do stem from the same problem that causes women to develop eating disorders in the first place. Therefore, I think that despite having separate requirements, they may have the same preventative solution. I think the distinction between the two is important because the treatments, once they have the disorders, shouldn't be different and not be approached in the same way. The American Journal of Medicine writes, both starvation and purging may initially cause these feelings of anxiety. The relief that stems from the lack of anxiety comes from the same place of either purging or just not eating. But I think the distinction is still really important. And then the fourth question is, a negative body image appears to play a key role in the onset of many cases of eating disorders. Can you think of ways the disorders could develop in the absence of body image disturbances? I think that eating disorders can develop due to feelings of loss of control. So I think if you experience a trauma or something that you just feel completely out of control, you can develop an eating disorder. I also think you can develop an eating disorder if you have like perfectionist tendencies and are like very, everything has to be perfect. Again, with the same idea of control. And then the third example I thought related to bulimia is if you go through something and you, or even if you're just stressed, like very, very stressed, you might turn to eating a lot or binging as a coping mechanism, which then can lead to purging and then guilt and eventually the eating disorder, bulimia. I found this case really interesting, specifically the success story of the ERP therapy, and I think that we can learn a lot from different types of therapy and how they affect patients. Overall, I really enjoyed reading this case and reflecting on the material. So thank you.